What can we do about all this stuff? Surely there is something that can save us from the heroin monster. There is a treatment that we can administer to people that if only we had more of it, we would be able to prevent all these deaths. And the treatment is, of course, come on, animation. Treatment is, of course, ventilation. It's not naloxone. The treatment for an opiate overdose is oxygenation and ventilation. And primarily that's with the BVM. Now, we use naloxone because lay people don't have access to BVMs. And honestly, a lot of first responders or EMTs or paramedics and a lot of doctors and nurses don't know how to use a bag very well. So we have that available for people when you don't have an option otherwise. But the treatment for an opiate overdose is ventilation. So if you are reaching for naloxone at any point, the first thing that you, as a professional rescuer, should have said was, hand me the bag and let's ventilate for a while here first. That should be what you do before you give somebody naloxone, before you think about giving them naloxone. The reason you should give them the naloxone is because you're not able to control their airway otherwise. If you can control their airway with BVM, there's actually a good chance that you won't need naloxone. Give them a couple minutes of ventilation, drive that CO2 back down, their mental status may improve to the point that you don't have to reverse them at all. Alright, so we have talked about it. What is naloxone? Naloxone is a competitive antagonist at the mu receptor to oxymorphine. So the shape of a naloxone molecule looks a lot like oxymorphine, which is the thing that causes the actual change at the mu receptor itself. It's a competitive antagonist. So what does that mean? That means that it will go and stick onto the receptor site itself, but it doesn't cause the receptor to actually fire. It effectively blocks the receptor so that the bad guys can't actually get to it. This guy is held away from the receptor by the little Narcan molecules floating around. We give a dose of somewhere around 0.4 to 2 milligrams, and you can repeat it. Naloxone lasts in the body for a half-life of somewhere around 45 minutes or something like that. Now, if you're curious, 1 dose of naloxone, 1 milligram of naloxone, should be enough to reverse a 25 milligram dose of heroin in an adult patient. There should be enough naloxone floating around out there at that point that it effectively blocks the effects of heroin at that point for about a milligram. 25 milligrams. Now, worth noting that if you have a whole bunch of drug floating around out there, then the chance that the bad guy is able to get onto the receptor because it's overwhelming all these other little naloxone characters is higher. And so you can overcome an amount of naloxone with a high drug concentration. It is possible that if you took a massive overdose that you overwhelm the effectiveness of the naloxone. Likewise, you should be able to overwhelm the drug if you give enough naloxone eventually. That may take a ton. The only time when that doesn't happen is when the drug itself sticks better to the receptor than the naloxone does. So in things like buprenorphine, that actually sticks better to the mu receptor, and the naloxone can't get in there as effectively. And so it's not. It's very difficult to overcome that sort of overdose. How should we be giving naloxone? Well, the way that we typically think about it is IV. Works well. Intramuscular works as well because a lot of these folks, as you all know, difficult to get an IV. They've already shot up a lot of their veins, especially as they're later on. But intramuscular will work, takes a little bit longer time. It's still as bioavailable. Intranasal naloxone, you avoid needles altogether and just give it a squirt in their nose. Usually we're giving about 2 milligrams at a time there. And it is technically 100% bioavailable, but it does take a while for that for it to be absorbed. And if you squirt the thing instead of if you don't get it on the mucosal surfaces of their nose and you squirt it down the back of their throat, then when you swallow it, it's essentially ineffective. So that won't work. But if you correctly give it, it works as well as IV naloxone does. Now you may ask, well, how come the person that I give intranasal naloxone to doesn't wake up like I did if I gave IM or IV naloxone? The overall time from when you arrive on scene to the time the patient wakes up, whether you give IN or IV or IM naloxone is almost about the same, but it's about 6 to 8 minutes. This works slower, but you don't have to worry about starting the IV. This works faster, but you have to start the IV first. The point is that you're going to have to bag this person in the meantime. You need to control their airway, you need to assist their ventilation if you're going to give them naloxone, because the reason you would give naloxone is to reverse respiratory depression. If you are going to give it, it's because they are respiratory depressed and you should be assisting their ventilations during that time. And so yes, intranasal works a bit slower from the time of administration, but the total time that you'll be on scene with it should be about the same. So whether you give IV or IN, the primary thing is that you're bagging the person until you get them awake otherwise. I throw nebulized naloxone on here because it has been reported. Chicago Fire was doing this. Basically, they would have folks that were still breathing, not new peri-arrest folks, obviously, but folks that seemed out of it. They would nebulize some naloxone, and it woke the patients up essentially just enough that they did not have the respiratory depression, but they didn't completely come up off the bed and start vomiting. So this is further detail in the awesome show Will It Neb, which is available on YouTube. Check it out, Will It Neb, episode 1. This is
Looks like he's falling off the wagon again. We gotta do something here.
Well, it looks like he's breathing okay. He's just altered.
Guys, I think he needs some Narcan.
IV?
Doesn't look like he has any veins.
IM?
He's all fat.
Intranasal?
Through his blowhole?
Will it neb?
There you have it, a narwhal booting heroin into its tail, and we make a whole big thing about it. So, what are the side effects of naloxone itself? Does bad stuff happen when you give somebody naloxone? The stuff that everybody talks about is probably not nearly, it is a safe drug, it's not nearly as pronounced as people have made it seem. And I think as the use of it has increased so much over the last several years, we've gotten away from the stuff that people say could happen when you give somebody naloxone. But what's traditionally been described? Number one, non-cardiogenic pulmonary edema as a result of naloxone administration. Now, this probably doesn't happen. The toxicology guys will say if it ever happens at all, it's exceedingly rare and not anything to worry about. The idea was you give somebody naloxone and they get flash pulmonary edema and they can't breathe and they have wet lungs and they cough up this pink frothy sputum. If you look at who actually first described that, it was from an anesthesia case, and they reported that this it was a relatively young kid, like an adolescent kid, 16, something like that, got naloxone to wake him up after he got some a little too much opioid in the recovery room after head and neck surgery. So the kid went in, had some sort of like oropharyngeal surgery, got a little bit too much pain medicine in the recovery room, and then got some naloxone to wake him back up at that point. And when he woke up, he coughed up some pink sort of frothy sputum. And they said this is clearly pulmonary edema, despite the fact that it wasn't radiographically confirmed or didn't really have any signs of pulmonary edema otherwise. But that's essentially the exact same cases that have led people to say this is a thing that could happen. Never mind that he had pink frothy sputum, probably because he had a little bit of bleeding in the back of his mouth after his oropharyngeal surgery, but nonetheless, that's what's reported out there. It's probably exceptionally rare if it happens, and if it does happen, what you're probably actually seeing is the unmasking of the pulmonary edema that he got from his opiate overdose to start off with. I'll leave it at that. Other thing that folks talk about, reasons that we need to be careful with naloxone, seizures are a potential result, especially if the patient has a pre-existing seizure disorder. Now these seizures, it's really nobody describes status epilepticus or anybody having problems as a result of that seizure, but it is theoretically possible that as you are waking up and beginning this terrible withdrawal state that you could develop, you could have a seizure. Certainly that's out there. And then the third thing that folks primarily harp on is this concern that you might get agitated and become violent towards your EMS professionals, or whoever it is that gave you the naloxone. And yes, this is possible, but again, why is it potentially possible? It's probably not the naloxone itself. It is that you were using, and you got high, and you fell asleep, and then you wake up, and probably you didn't get bagged, so your CO2 is 120 and you don't know what's going on, and there's 5 or 6 big guys all standing around you in uniform, it's hard to see, you're not sure what's happening, you feel like crap, and you get real sick to your stomach. And so yes, these folks get agitated and their fight or flight response kicks in. So one of the ways we can potentially avoid that is by giving smaller doses and not completely like making everybody have a terrible day when they do this, as well as bagging ahead of time to ventilate them and blow down that CO2 so they're less confused when they wake up. Overall, is naloxone safe? Yes, but do keep in mind that the primary treatment is ventilation and BVM. The indication for naloxone, as I've sort of mentioned, is the treatment of respiratory and CNS depression as a result of presumed opiate intoxication. There's lots of other reasons that it might get used. Now keep in mind that as you're thinking like, oh man, this son of a bitch, he's overdosed again, I'm going to wake him up. So he's going to get 4 milligrams of IV Narcan, he's going to have a bad day. Keep in mind that essentially nobody is out there overdosing with the intention of overdosing. Nobody's out there using it like, I'm going to overdose today. Sounds so cool. Because of all the terrible things that happen. Nobody wants to get naloxone if they can avoid it, generally speaking, because it makes you feel terrible. And it wastes a high, and it wastes the money that you spent on it. And everybody knows that you could potentially die as a result of an overdose. So nobody's trying to do this intentionally. It happens, but please don't make this a punitive sort of situation. Now, there is a pre-hospital scenario that we've got to talk about. What typically happens, you find somebody on the ground, you call 911, EMS arrives, we give naloxone, the patient wakes up, takes a big breath, is suddenly alert and oriented, and vomits all over the place, and then takes off down the street. Because again, there's a lot of uniformed people around and they don't want to go to the hospital. Now, you think back in your mind as you watch the patient running away, and you remember somewhere somebody said the half-life of naloxone is somewhere around 45 minutes or so. The half-life of most of the drugs that people use are somewhere around 2 to 3 hours, if not longer. If it's methadone, it's a day. So what happens if the naloxone wears off and then the patient, those drugs come back into effect, and is the patient going to die? Am I going to get in trouble? Are they going to pass out while they're driving? What's going to happen? So it's enough to make us worry. What do you do about it? The question is, do we let them go? Do we try to hold them down and restrain them ahead of time? Do we call the cops to go chase them down? Should we have just intubated them in the first place, not woken them up and taken them to the hospital? Because, again, once you have the airway controlled, there is no reason to give somebody naloxone. If you intubate somebody, there is no reason that you should be giving them naloxone afterwards. That's the last thing you want to do. Don't forget, too, that as you're making this calculus in your head about whether or not you're just going to let him run, that he may have friends nearby. Somebody probably had to call 911 and find him, and these friends are usually not fans of certainly law enforcement, but government in general. This could potentially turn into a dangerous situation for you. So how should you handle it? What should you do? Well, number one, we realistically, once you wake the person up, if they're alert and oriented and can have capacity to understand the consequences of their actions, if you tell them, hey, if you go away, you could potentially die, then that person is allowed to go away. Even if they were stoned a second ago, once you reverse them and they're alert and oriented, they're able to make that decision, they can go. So we cannot hold these people, we can't force them to go to the hospital. We sometimes do the halfway, you can either go to the cops show up, and if you can get them there, they'll either say you can go to jail, you can go to the hospital. It seems to hardly work, but it sort of does happen. But we can't actually restrain these people, tie them down, hog time, and make them go to the hospital if they refuse. That's their decision. It may be a bad decision, but it's what they can do. There's some other stuff that you can do about it. Number one would be to reduce the dose. So instead of giving a whole 2 milligrams at a time, this is mostly talking about IV, instead of giving 2 milligrams or 1 milligram or 0.4 milligrams, what you can do is reduce that dose even further. And the recommendation is to give 0.04 milligrams at a time every 30 seconds to a minute or so, and titrate until the patient has reversal of their respiratory depression and is protecting their airway, but is not 100% awake. And then let them wake up slowly after that at the emergency department. That was the recommendation from the actual toxicology guys, was reduce the dose of naloxone that we give, at least in boluses, and give it more frequently in small amounts. Let's say that didn't happen though, you weren't able to get the patient to either go to the hospital with you or kind of strong arm him into it or anything like that. If he takes off, if he gets naloxone as a result of a heroin overdose and then takes off and disappears around the corner and you don't get him back, what's going to happen to him? Well, there's actually a number of studies out there that say this is not probably as big a deal as we think it is. When these folks looked at medical examiner reports and hospital admission reports for folks that were seen by EMS, presumed to have an opiate overdose, got naloxone, and then took off, refused to go to the hospital. Essentially, none of those folks ended up in the medical examiner's office within 24 hours or so, which is pretty good to say that the incidence of rebound overdose probably is not really a thing that you have to worry about. Again, same thing, big study. Lots of folks who got naloxone treated, not transported. Everybody essentially ended up okay. So this seems fairly safe. And if you want to see an actual study of could we just release people overall, this is a study of folks in Copenhagen. These guys have access to, they can essentially search government records and it keeps track of everybody. These guys would say if you are presumed to have an opiate overdose, you show up on scene, we give him we give him naloxone, and then if he's alert and oriented, has essentially stable vital signs, we just release them and say you don't have to go to the hospital. Out of some like 1,500 patients, there were 3 that died in the next couple of days that might have had anything to do with their drug use, and it sounds like at least 2 of those were probably because they used again, not because they had a rebound effects of their initial drug dosing. So this is probably an okay thing to do. We should still be telling people they need to go to the hospital, but if they decide to take off, they're probably going to be okay. Again, don't tell people to do that, but it's probably not that big a deal. Other thoughts you could do about things that may make it easier: should you give 2 milligrams IV, or could you give 2 IV and then give them a slug of 2 IM just to get more naloxone in them, let it sit around for a while, or maybe 2 and 2 and 2 and just give them a ton. Remember that as much naloxone as you give somebody, that's how much worse they're going to feel afterwards. So if there's not really a benefit, if there's not really that much danger to the person refusing, we probably shouldn't be telling them, well, you can go, but only if I give you another shot in your arm here or something like that. And of course, the ultimate question is, could we just stay out of the whole naloxone thing to start with? I would make the case that among paramedics and EMTs and professional rescuers, we probably don't need naloxone. We probably shouldn't have it. It probably is something that we spend a lot of money on. Lots of fire departments spend lots of money on lots of naloxone and give it to people 3 and 4 times a day sometimes. A bag is cheaper, a BVM is cheaper than a dose of naloxone. And if you BVM the person, if you can successfully control their airway through any number of means that we are set up to explicitly do, then we don't need to wake the person back up fully. Again, if you can control their airway, if you can maintain them on supplemental oxygen, if that's what it takes, you don't have to wake this guy up. Certainly if you place an advanced airway or an ET tube, and I'm not telling you to go intubate a bunch of people or try to intubate a bunch of people that you shouldn't be trying to intubate, but try bagging. Try that first, and there's a good chance that we can stay out of this whole should we give them naloxone, then what do we do with it, if we just practice the good basic airway stuff first. Now again, your peri-arrest patient that we are trying to wake up as fast as we can, okay, I can kind of buy that, although again, we probably should be reaching for the bag first. But remember, the treatment for an opiate overdose is not naloxone for us. The treatment for an opiate overdose is ventilation. And then if you have to use naloxone, or if that's the thing that you've decided you're going to do, we should do it judiciously and in small amounts and titrate to effect rather than just slamming in a whole bunch off the bat. So, key points: opiate overdose continues to be a big problem. It is now likely the contaminants that are really driving it with in terms of fentanyl. Synthetics are a big problem. As I just kind of mentioned, naloxone is not the primary treatment for opiate overdose. It is the backup, or if you don't have anything else you can do. So if you're a sheriff's deputy, or if you're a lay person, or if you're also a drug user who happens to be with somebody so you can do safe injection stuff, then naloxone makes sense because you don't have the other tools. But for us, if we reach for naloxone, we better have had a bag on that guy's face for some time before that. Intranasal naloxone is effective, but it does take time. So why do people get 6, 7, 8 doses of naloxone and they still don't wake up? Well, because they're getting a dose every 30 seconds because somebody squirts it in their nose and waiting 30 seconds. Here, let's wait 5. Squirt. And everybody's surprised when the person isn't awake already. So intranasal naloxone is effective, but it takes time, anywhere from 6 to 8 minutes. And number one, first and foremost, don't get yourself hurt. Give them a second shot at life, absolutely. But if they make bad decisions, they make bad decisions. And it's not worth you getting hurt, shot, stabbed, wrestled to the ground, or lose your job over. So protect yourself first. And of course, as always, emsgrandrounds@gmail.com. Check out our Facebook page. Check out our YouTube collection. And we'll see you next time.